When it comes to ECGs, you might have seen a diagram that looks something like this. In today's tutorial, I'm going to make sure you know exactly what it means and why. Let's start with the very basics. So, the heart itself is living tissue. It needs its own supply of oxygen in order to keep the cells alive and to produce ATP to power its contractions. The catch is, though, that the heart muscle cells can't actually access the blood inside of the chambers, and that's because the chambers are lined by an impermeable endothelium. If the chambers were permeable, then the heart wouldn't be very useful at pumping, right? So instead, you've got this pair of arteries, the left and right coronary arteries, that branch from the base of the aorta to supply the heart itself from the outside in. Now, these arteries have many branches, and you learn their names in first and second year. But for today's purposes, I'm going to present a simplified version. So if you look at my diagram here, this is the heart and this is the aorta. The left coronary artery gives off a branch called the left circumflex, which wraps around the side of the heart, supplying that lateral surface. Meanwhile, its other branch is the left anterior descending artery, which comes down along the front of the heart. It's sometimes also called the anterior interventricular artery because it overlies the interventricular septum. And then if we go to the right coronary artery, it gives off a branch called the right marginal, which travels along and sort of supplies this undersurface of the heart. I guess you could say it's the right margin of the heart, but if you think about how the heart is tilted, its right border becomes its underside, its inferior surface. Meanwhile, the right coronary artery wraps around the backside of the heart and in most people gives off the posterior descending artery, which supplies that posterior surface. So as a quick summary, the circumflex artery is supplying the left lateral surface, or just lateral surface of the heart. The LAD is supplying the anterior surface, the right marginal is supplying the inferior surface, and the posterior descending, which arises from the right coronary in most people, supplies the posterior surface. Now I want you to file all of that information about coronary arteries away in your brain for now. We'll come back to it later. We're going to talk for a bit about ECG leads. Now, an ECG is really just a voltmeter, right? You've got two terminals and it's measuring the electrical voltage between them along that vector. So if you stick them on 2 points on a person's chest and get them to sit still so that they're not using any of their other muscles, then you're able to record the electrical activity going through the heart in that direction. Now, in practice, we don't just record between that single pair of dots. We actually put enough stickies on the patient to record 12 different leads at the same time. The first three are the so-called limb leads, 1, 2, and 3. Lead 1 goes straight across the chest from right to left. Lead 2 is 60 degrees down from that, and lead 3 is another 60 degrees around. Then we have the augmented limb leads, AV left, AV right, and AV foot. These split the circle exactly into thirds along this Y shape. And finally, we have the 6 chest leads, V1 through to V6, and these actually go in the transverse plane, parallel with the ground. If an electrical impulse travels in the same direction as a lead, then it is seen as a positive deflection in its trace. If it travels in the opposite direction, it is seen as a negative deflection. Now, you know that normal electrical impulses in the heart start at the SA node, which is in the top right, so the atrium depolarizes from the top right down towards the bottom left. That's about the same direction that lead 2 goes in, which is why you see the P wave as a positive deflection in lead 2. Meanwhile, it's opposite to the direction that AVR goes in, which is why AVR's P wave is always negative. So once again, we have our limb leads 1, 2, and 3, our augmented leads AV left, AV right, and AV foot, and our 6 chest leads V1, V2, V3, V4, V5, and V6. You can search 12-lead ECG 3D model on Google, and I found this really cool rendering that someone made showing you the directions of all 12 leads. Now that we've discussed the coronary circulation and the ECG vectors, it's time to put them all together. You know that if you block a coronary artery for long enough, then the part of the heart it supplies will die. That's called a myocardial infarction or a heart attack, and it manifests on an ECG as elevation of the ST segment. Now, I won't go into the physiology of why ST elevation happens. Dr. Mike Todorovic has a great video on his channel if you're interested. But for now, just know that you get ST elevation when that part of the heart dies. So, if you block the left circumflex artery, the cells in that left lateral aspect of the heart will die, and you would get ST elevation in the leads that point in that direction. So what leads would that be? Well, lead 1, obviously, because it goes in that direction, AVL also goes towards the left, and if you look at the diagram, V5 and V6 are pretty close to 1 as well. If you block the left anterior descending artery, you lose the front part of the heart, and so you see ST elevation in the leads that point most forwards. So that would be your first couple of chest leads, V1 through to V4. And if you block the right marginal artery, or even block further upstream like in the right main coronary artery, you lose the inferior aspect of the heart, and so you see ST elevation in the leads that point most downwards, so AV floor, 2 and 3. Now if you label those territories on a 12-lead ECG, that is what that diagram at the start was. Now, what about the posterior surface of the heart? We don't have any leads that look directly at the posterior myocardium. So what do you do if you suspect the patient is having a posterior MI? Well, you can stick a couple of additional leads on the patient, V7, V8, and V9 wrapping around to the back, or alternatively, you can look for reciprocal changes in the anterior leads. Like I said earlier, when a signal goes towards a lead, it is seen as a positive deflection, and if it goes away from a lead, it's seen as a negative deflection. So if you have ST elevation going posteriorly, you can expect to see ST depression in the anterior leads, V2, V3, and V4. As a general rule of thumb, posterior MIs cause reciprocal changes in the anterior leads, and anterior MIs cause reciprocal changes in the inferior leads. Inferior goes to lateral. Lateral can go in both directions to inferior or to the septal leads overlying the interventricular septum. Septal MIs wrap all the way around back to the posterior, and you can use the mnemonic PAILS to remember that. So finally, here are a couple of basic examples. Have a look at this ECG. Which artery do you think is being blocked here? You can pause the video if you want to try it yourself, but you'll see this ST elevation in V2, V3, and V4, maybe a little bit in V1 and V5 as well. So very much these frontal anterior chest leads. So the artery being blocked is probably the left anterior descending. Now in this one, you see very prominent ST elevation in 2, 3, and AVF. So this is definitely an inferior MI, and the artery being blocked is probably the right marginal or even the right coronary. You will notice some reciprocal changes as well in some of the other leads. And that's it. I hope this tutorial and those exercises were useful. They are very introductory, but whether you're a first year learning it for the first time or a fourth year interpreting ECGs on placement, hopefully things will make a little more sense.